Our next speaker is Dr. G.S. Prabudoss, and his topic is comparison of conscious nasal versus oral video upper GI endoscopy. Thank you.
Good morning. Welcome to the first session. This is something that is very close to my heart because this has been my practice since 10 years, and it's a comparative study between conscious nasal endoscopy versus conscious oral endoscopy in an adult for a regular upper GI endoscopy. It's a small video of a normal oral intubation where the patient, can you just play the video? Yeah, it's a common position of the patient left lateral, and the oral intubation is done, before which a small local anesthesia is sprayed. And after that, the oral endoscopy, a normal size, enters the oral cavity, then goes to the esophagus, stomach, and the second part of duodenum, and come back, you find whether there is any reflux or not. How does this differ with my technique is, I do the oral pediatric endoscope as a routine diagnostic nasal endoscope for adults. So which means the pediatric oral endoscopy size is about 5.5 millimeter, which is designed for oral endoscopy for a pediatric cases. That I use it for a nasal in an adult for all diagnostic, and you can see how advantageous and how pleasurable the procedure is, not for the surgeons but for the patients. Can you play this video? And this is the only procedure I would say the patient will be talking during the procedure. Just see the intubation. I talk to the patient every time. He is not a sedated patient. He is a patient who is conscious, aware of the entire nasal procedure. And once I move in, I tell him this is where the endoscopy is moving from the nasal route, and I go for the cricopharyngeal intubation slowly into the esophagus, insufflate the stomach, and I talk to the patient, and he also replies back, do you have this problem, that problem. So clinically I am able to interact with the patients because he is very cooperative, very comfortable during the particular procedure. Can you play this video, please? Yeah, this is the pre-operative workup for a bariatric patients. See, bariatric patients are always a challenge because giving an IV sedation in an endoscopy suit is always a challenge. This is just to show how the patient, just see the facial expression. It's the cricopharyngeal intubation that gives so much of gag, so much of difficulty, and patient doesn't enjoy the procedure, I would say. But in IV sedation, it doesn't matter. Whether you do a nasal intubation or an oral intubation of endoscope, it is all the same. But in a developing country or in a country vast like India, where endoscopy is an OPD procedure, where this can be offered as a procedure of choice. Endoscopy or introduction is instrumentation to look into the visceral organ to know whether you have any gastrointestinal complaints as such. The background is endoscopy is mandatory almost for all the GI complaints, whether it's an upper GI or lower GI. But the problem is patients do not accept this procedure because they are having a dreadful experience with the pain. Whether their relatives or somebody has told them that don't undergo this procedure because it's very painful, you have a sore throat, you cannot speak for 2-3 days, and all those things sway away the patients from you, and you also have no choice not to force the patients when they don't subject yourself to conscious sedation. And the patient, this reason for this study was my father underwent an upper GI endoscopy when I was an intern by a very famous endoscopist, and I could see the oral intubation like a fish on the bait. My father was just jumping on the table, and when I asked the endoscopist with all scare and fear, this is how you do endoscopy? He said, yes, this is how it is. The patient has to tolerate the procedure. Then that was on back of my mind, and when I was in a medical college, fortunately, I had a pediatric endoscope. I did it for an MBBS student. She was just closing her eyes, and after I finished my nasal intubation and came, she said, Doc, is the procedure over? That was the spark that came, and I thought, let me further dig on this procedure and make it as a standardization procedure. And I compared 1,000 cases, it was a long back procedure, 1,000 cases nasal versus oral intubations for all patients for a diagnostic endoscope. Nasal packing was done for all the nasal endoscopy patients with your normal 10% xylocaine with oxymetazoline. Mouth gag is not used in any of the patients, and the pain score is used as a main scoring method, and the other factors like gag, nausea, tolerance, and other features are also used. And all routine patients except that deviated nasal septum, nasal spur, and sometimes who are having a nasal spur are not used. Pain is a main score. And if you compare this graph, if you can see, there is 0 pain score for nasal intubations, and there is 2 to 4 pain score for oral intubations, and out of which all procedures that can be done during a nasal intubation itself, because there is no mouth gag, no need for assistant to hold the patient, no need to terrorize the patient, and no need to spray anything, no gag reflex, and this is the only procedure where patient can speak and there is absolutely no pain. And you can see the clarity of the imaging. It is as comparable to any oral larger images that you can see. All parts of the stomach very well seen, and the take home message is, and I got a patent which has been applied, and I got it in 2021. And endoscopy is not an optional procedure. It is to be done for all GI complaint patients. When it can be offered painless, I feel this can be a procedure of choice for early diagnostic all oral endoscopies to be done to all the patients in your OPD itself comfortably. Thank you for this opportunity.
Thank you very much, Dr. Prabudoss.
Thank you, sir. Very nice to meet you, sir.
For introducing, a new approach, the nasal endoscopy. Yes, definitely there are advantages are there. But my only query was that the length of the pediatric endoscope and the length of the...
It's the same, sir.
They're the same.
Same.
But how is it that, it occurred only to the surgeons? Because one day I was told that, the even ERCP was devised by the surgeons, not by the gastroenterologist.
No, actually, the length is the same. Actually, we use most of the pediatric endoscope even when there is an esophageal stricture, when there is a difficulty when you have a post-corrosive strictures. So that time when you intubate, you use the the pediatric endoscope as an oral endoscope. But only thing is, when I use it, as you saw in the video, the comfort level of the patient is phenomenal.
Yes,
that's how you are able, and I have all the attendants inside my endoscopy room. They watch, the father watches the son, the wife watches the husband, not out of the fear, but just we will be able to share so much information because the patient is comfortable and they are also okay with standing inside the procedure room.
I think this also emphasizes that every surgeon must learn upper and lower GI endoscopy.
Definitely, sir.
So I think it must be a part of the curriculum.
So this is just the diagnostic, or any therapeutic procedure can be done?
Therapeutic as such, you can take biopsies, definitely. And H. pylori I routinely do for all patients. But only thing is, a foreign body removal cannot be done. Number one. Number two is, if you have to ask for a sclerotherapy or a banding, that cannot be done with this procedure.
Okay. Thank you, Dr. Prabhudas.
Thank you, sir.
Thank you.